For those of you who don't know me, my name is Archna Gupta. I'm a comprehensive family physician and a clinician scientist and the quality improvement lead for the collection and use of social demographic needs data at the St. Michael's Hospital Academic Family Health Team. And I'm going to be your moderator for today, and I'm really excited to share our lineup, our panelists for today. We have with us Noor Ramji, who's also a comprehensive family physician, and she's the Family Health Team's Quality Improvement Director and has led several quality improvement initiatives related to chronic disease management, timely access, patient experiences, and also most recently, increasing attachment and understanding and how to improve health equity. Nassim Vahidi-Williams is the manager for community and patient engagement at the St. Michael's Hospital Academic Family Health Team. She is a health systems expert with over a decade of frontline experience and is dedicated to addressing the social determinants of health for our patient populations. And Talia Levitt is a recent graduate of Harvard University, where she completed a Bachelor of Arts with a minor in global health and health policy. And she has been a key player on our health equity team this year, supporting work particularly around data governance. Before I turn it over to our panelists, I thought it would be helpful for us to chat a little bit about why it's important to collect social needs data. And although today's session is really focused on governance of demographic and social needs data, it's really important to first understand what it looks like to implement the collection of social needs data and how this data can potentially be used. And that in turn affects governance. And so, Joe, I'll ask you to take it to our next slide. Yeah, so to highlight the implementation process, I'm going to share with you an example of what it has looked like for us at the St. Mike's Academic Family Health Team in Toronto. And for context, our clinic is an academic family health team. It's made up of 80 family physicians, dozens of interdisciplinary team members, and clerical staff and trainees, and we're spread across 5 different locations. And so our implementation journey actually began in March 2022. So if we think about it, we're in February 2026. So several years ago, almost 4 years ago, we started talking about how we were going to implement social needs data collection. And we spent 6 months actually doing stakeholder engagement. So talking to our clinical leads, talking to our patients, talking to our information and IT team about how we can actually ask these questions that's integrated with our electronic medical record, thinking about how can we link this tool with existing appointment reminders, and taking that time to actually train every patient-facing staff, provider, learner, anybody who talked to patients, so clerical staff, our consults team staff, about what health equity meant, about why we were collecting social needs data, so that if a patient asked anybody on the team, they would know how to answer that question and they would know how to access resources. And so it was really about spending time doing that. And then also, really importantly, developing patient brochures about what this initiative was about, and also developing patient resource lists, which Nassim is going to talk about later, but making sure that if someone identified a social need, it wasn't a black hole, that we could actually offer them with resources to address that need. So 6 months doing that, and then we piloted implementation at one of our 5 sites. And so we sent this health equity questionnaire out to all patients in an appointment reminder, and we also offered it in our waiting rooms by tablets, and it was offered to them by clerical staff. So we took what we learned in 6 months at one site, and then again, we went back to the drawing table of, okay, what we learned a lot about what works and what doesn't work. So what do we need to revise and adapt before we actually implement this across all 5 sites? So we learned that, we did the training, but the staff didn't really like the way the training happened. So we took that feedback and we changed the way we trained our staff. We modified the consent form after we heard from patients and from our physicians and our staff about how some of the terminology was unclear. We heard from patients that the brochure was great, but it didn't meet everybody's needs. So having a video that explained what it was helpful. And you'll see we have some QR codes about the videos that we made. We engaged with clinics leads across all the 5 sites to say this was coming, that this was going to be coming to their sites. And then we trained all patient-facing staff across all 5 clinics. And we started to have this discussion about data governance. So we started talking about data governance before we even started to collect the data from most of our patients. And then again, March 2023 to November 2023, that took us that long before we actually scaled up the implementation to all of our sites. And we learned in our pilot that the tablets didn't work, so we decided to just start off with appointment reminders. But we realized that we were missing a lot of patients, right? Like patients who have an email on file is not necessarily the most equitable approach for reaching our patients. And so at the same time, we were concurrently planning how can we reach our hard to reach patients and populations. And so we actually applied for funding for a grant. And we brought on a community surveyor, so someone who could actually go out and reach out to the patients who were identified as hard to reach. And we had a pool of individuals who came from priority postal codes and individuals who had been identified in their electronic medical record as having a disability, or those who are transgender, or those that had a schizophrenia or bipolar. So individuals who are typically left out of surveying. And we really focus on reaching out to them. And it was really fantastic what we learned. So, if we think about numbers, so if we think outside of our hard to reach population, between September 2022 and July 2025, about 43% of patients who received the health equity questionnaire completed it. And in this hard to reach patient population, so those that are very hard to reach, when a community surveyor reached out to them, almost 70% of them completed the survey. So it was really promising to see that. So once we kind of had all of this data over a few years collected, and we had really tried to reach out to some of our harder to reach populations, we recognized that out of our total patient population pool that was over 18, we still had only reached 20% of patients, but we wanted to figure out, okay, like at what point can we use this data? And so that in the fall of 2025, so just this past November, we held a data governance workshop, which you're going to hear more about today. And so, Joe, I'm going to ask you to go to the next slide. Again, I wanted to clarify about what I mean about using data, because data can actually be used at different levels. So since data collection has started at our site, we have been very committed to using individual level data. So that means that when a patient identifies a need, we can see it in their electronic medical record, and we can identify them at the patient level. So if a patient says they're having a hard time making ends meet, if they can't find transportation to clinics, that they can't find affordable food, we can provide them with resources to address those individual needs. But what we haven't started to do yet was organizational level data. So who are we serving in our groups, in our actual patient, in our clinic overall, and how are our services organized to meet the needs of our patients? And so that's kind of a meso level type of use of data. And then at the macro level, which again, we're not at yet, once there's readiness, once we have good quality data, there's actually opportunities to pool data with other organizations across health systems to provide a better overview of patient needs, and to support changes that would provide for equitable healthcare systems. So that's enough of me giving background. Now that we have a basic understanding of kind of what we're talking about and how we collect and implement and use social data, I would really like to turn the focus of this seminar over to our panelists to talk about data governance. So I think we can end slides. Great. And to get us started, I'm going to ask Talia, could you please explain what data governance is and how it's been applied to social needs data collection in primary care settings outside of Canada?
Yeah, thank you for the question. So, yeah, I'll begin by just giving a broad definition of data governance, just so we're all on the same page, because it can be a really sort of big, maybe elusive term. So, I'll get us all on the same page, and then I'll go into some examples about how data governance has been applied in other contexts. So, one definition of data governance that I like comes from the Pan American Health Organization, which defines data governance as a set of practices for making decisions about data and for managing data throughout its life cycle to optimize the organization's capability to use data to generate information that informs policy, strategy, and operational management. So, in other words, data governance just encompasses all of the structures that determine how data are collected, protected, shared, and used, and who gets to make those decisions. And of course, this is really important to think about when we're moving from individual collection of sociodemographic data to broader use on an organizational level. So I've done a little bit of research about how data governance has been implemented in other contexts, particularly in US-based primary care settings that began collecting social needs data a little bit earlier than we have. And I've just pulled out some common governance approaches and themes that have been really successful in other contexts that are helpful to learn from. So one big tool for data governance is establishing oversight and accountability. So almost every primary care team that I looked into that has implemented social data governance had a dedicated governance committee, which was made up of diverse individuals from across the primary care team who understand and are really committed to social data use and governance. And these committees just oversee all decisions regarding social data use to ensure accountability and consistency in data use. Oftentimes, they might be supported by subcommittees that have specific roles, but really having a group of people that is knowledgeable about social needs data and is responsible for making those decisions ensures quality and equity in data use and prevents inappropriate or maybe ad hoc use of the data in ways that aren't appropriate for such sensitive information. But beyond the voices of people that are part of a primary care team to be making these decisions, of course, community and stakeholder engagement is really, really important to ensure that the populations whose data are collected are actually helping to shape how it's used. So many teams have established community or patient advisory boards to embed these perspectives into governance structures and decision making to make sure that what we're using the data for actually aligns with what patients want and need, and to maintain that trust. And Nassim later will talk a little bit more about that and how we've done that. So beyond sort of these committees and people helping to make the decisions, it's also important to think about how do we track the social needs data that we're collecting in a way that's accessible and accountable. So many teams use things like system-wide dashboards that all of their social data can feed into, and these are user-friendly and accessible. And on a broad level, they can use these dashboards to identify unmet needs, monitor trends and patterns, and actually figure out where those gaps in resources are and inform resource allocation and program planning on a clinic level. And to take this one step further, some teams link clinic level data to community level data, so things like census data, to add additional context, ensure representativeness of the data collected in a clinic. So if there are major discrepancies between what we find in our clinic data and what we know from the census, maybe that's something to look into. And again, to identify those hotspots of unmet needs and support that broader population level program planning or advocacy. Okay, so moving to how we use the data and who can access it, because social needs data can be particularly sensitive, governance frameworks really need to emphasize access controls and privacy preserving technologies to make sure that we're protecting patient confidentiality while also enabling data sharing where it's relevant and where it's helpful. So some systems that I found actually were able to develop specific role-based permissions within their electronic health records to allow data sharing with relevant community partners on a really strict need-to-know basis. So partners that might help with food assistance or housing security, how can we allow them to access information that's relevant while still protecting patient confidentiality? So sort of balancing interoperability and coordinated care with confidentiality and minimizing risks of harm. And then the final sort of big question and theme that emerge in these governance structures is really clearly defining ownership and stewardship of the data. Most health systems do retain institutional or organizational ownership, but a really critical caveat that I wanted to mention is Indigenous data sovereignty, which is a really distinct consideration when we're thinking about governance of sociodemographic data for Indigenous communities. So you might be familiar with frameworks such as the OCAP principles, which stands for ownership, control, access, and possessions of First Nations data. That's just one of several frameworks that emphasizes the need to critically think about Indigenous data sovereignty sort of as its own category. Candidly, it's something we're still working on in our approach, but that's a really key consideration, I think, for a lot of our communities. So just to conclude, hopefully now it's sort of clear why governance is such a key tool that turns social data from simply a collection exercise used on a one-to-one basis into a tool for broader action. And of course, this relies on intentional, responsible, and transparent governance to ensure that social data are really used effectively and ethically and in ways that benefit the patients and advance health equity on a more organizational level. So I'll wrap up there with that little primer on data governance, and I'll turn it over for the next question.
Thanks so much, Talia. There was so much that was embedded in there, and just for the audience to know, we're going to build on some of those concepts kind of in our next question. So I'm going to hand it over now to Nassim to really share specifically around how community engagement has shaped social needs data collection at the St. Michael's Hospital Academic Family Health Team, and how this should influence future governance structures as we move forward.
Thank you. I'm so happy to be here and to be talking about this particular topic. Community engagement, obviously, as you've heard from our last two speakers, has really shaped our approach because, of course, social data in general, but social data in particular can feel sensitive, in particular for folks who've experienced stigma, racism, poverty, or judgment in healthcare. If we want people to answer questions around social data honestly, the process really has to feel safe. It has to not feel like surveillance and not really tokenistic, like checkboxes. Before launching our health equity questionnaire, we, as you heard, invested in staff preparation. So there was a lot of training that happened, and we created videos, we created manuals, and we held staff training sessions so that staff could understand the purpose of the survey and how to introduce it clearly and how to ask questions in a respectful way. We focused on choice and control. So patients can, and this will be familiar to a lot of you, I think, in the webinar, but patients can skip questions. And we explained why we were asking, how the information would be used, and what it would not be used for, importantly. And our goal as a team, sort of overseeing this implementation, was to reduce fear and increase clarity for the patients that were filling out the survey. Again, as you've heard a little bit in our implementation slide, we paid attention to how questions were being asked and how the clinic responded. So we adjusted things as we kind of went forward in response to patient feedback, in response to clinicians' feedback, in response to frontline staff feedback. And staff really understood over time, and I think as a result of our training sessions, that the support was needed to ask gently, to avoid assumptions, and to know what to do if someone becomes uncomfortable. And we, again, sort of worked with the principle of how we collect the data was just as important as what we received in terms of what we collected. We tested approaches to reach people. So you heard earlier, we had a 6-month RCT where we included we included someone on our team who was a community health surveyor, and she was absolutely lovely and did the job really well. And essentially what we learned from that approach was that it's successful, that having someone who has the particular skills to reach out to folks who are hard to reach, to have that intentional, meaningful conversation, to prioritize that conversation and to be there to kind of listen to the needs that were present, really made a difference in terms of how willing folks were to respond to the survey. And we had this dedicated team member, complete the survey with the patients. And again, as you heard, we saw a really strong uptake in terms of the responses when this particular individual was intentionally doing this work. Um, and just to say a little bit about the brochures that we mentioned earlier, this was really about sort of immediate benefit for folks that were completing the survey and not leaving not leaving someone in a position where if a need was present and they were completing a survey with a staff member and something came up that the need would just be sort of put aside or ignored or not paid attention to. We wanted there to be some kind of intervention available to folks who were talking about this sensitive information and taking the time and making the effort to share this information with us. We created the brochure that was offered to every patient completing the survey. It really aligned with the questions that were asked. So we created sections of the brochure that aligned with the questions that were related to different pieces of social needs data that we were asking about, and pointed to relevant programs and community services that would be available to patients to kind of meet those needs. Trust was obviously a core part of our data quality. Strong relationships and consistent sort of respectful interactions led to better completion of the surveys, like we saw with our community health surveyor and that RCT. I think over time we learned that there are certain approaches that work really well with folks that we are calling hard to reach. And I think Dr. Gupta talked a little bit about how we defined hard to reach earlier in this webinar. And we kind of made those decisions based on the available data that we had. And what we were able to respond to as a family health team, like what we could actually act on. I'll speak a little bit about the patient engagement structures that we have at the family health team. We have four sort of structures for patient engagement or community engagement at the family health team. One of those structures is sort of embedded in what we call a social determinants of health committee. So we have an internal committee at the family health team of staff, and it includes patients, where we meet sort of regularly throughout the year, and we talk about this sort of social needs data collection as well as other social interventions that we have at the family health team. And the patients that sit on this council or this group with us are just as active members as everyone else, and make decisions with us, and we kind of co-create as we go forward. So that's sort of one structure that we have where patients are partners and give us the feedback that we need to improve and go forward. And then we have three separate councils, one general patient and family advisory council that's been in place for about 8 years, going on 9 years now. And then we meet monthly with and gather sort of feedback and guidance and direction from. And then we also have a youth council, and we also have a seniors council for folks that are 55 plus. Those three councils meet monthly, like I said, and we learn a lot from partnering with the folks on those councils. Going forward, these engagement structures will shape governance decisions, including who's involved in decision making, what kind of analyses or reporting are appropriate, how we set safeguards and access, and how we communicate back in plain language about what we learned and what we changed. And I'll just end with saying that loop back is something that I've heard from patients is really important. When you ask the questions, there has to be some sort of sharing back with community in a way that makes sense and is meaningful. Otherwise, you're not sort of serving the folks that you're asking or taking the information from. So maybe I'll stop there, and I'm happy to take questions later, but for now I'll turn it over to Dr. Ramji.
Thanks so much, Nassim. So we've heard kind of globally what governance is, and then we've heard really strongly about the patient-centered focus that we've had at the family health team and the different ways that this has been done pragmatically. And so I'm going to now turn it over to Noor to ask, could you explain a little bit about how data governance is being applied to manage the St. Mike's Academic Family Health Team demographic and social needs data that's been collected and and how that kind of outlines next steps.
Certainly, thank you so much. I think one of the things that we've been fortunate at the St. Michael's Academic Family Health Team is that we're also a research site for the University of Toronto Family Medicine program, which means that we've had experience with health-related data and how do you actually handle it, and some of the ethical considerations with respect to consent and having a process in which requests for data are reviewed. Potentially an ethics board has a review of research projects. And so having some experience there led us to have a keen sense of wanting to ensure that we had the same, if not more, protective shells around this type of data, and sort of came to the conclusion, and this is also inspired by some of Talia's literature review work, that really made sure that when we are looking at how we use this data, that it's really purpose driven, that it respects the privacy and the trust of patients, and that it's also equity informed. That are we actually getting the appropriate representation of voices heard when we extract this data and use it for program and services assessments. And as Archna mentioned, we really started this journey with being really intentional about the collection of data and what we wanted to collect and its limitations as well too. And really at the end of the day, we really wanted to make sure that those questions that we asked were tied to a defined use. And I think this question may be in the chat about, how do we make sure that we had questions that we were asking that we could provide supports for? And I think it was something that we had a lot of feedback back from our team. So when we asked a question about medication coverage, if a patient said that they didn't have medication coverage, ensuring that we had pathways within our pharmacist team that could support patients with considering provincial choices of drug coverage. And we also intentionally chose not to ask the specific question of indigeneity and Indigenous background because we didn't feel ready or equipped to support patients with pathways to dedicated services. I think we're continuing to work on that journey, but also knew that we weren't ready to have a data governance structure that worked with Indigenous community members to really think about the data sovereignty. So there were questions that we had to hold on that we were really keen on asking, but noticed that we weren't actually in a place that we were ready to provide supports for. And really important that when we thought about our limited data collection efforts, that they really were communicated to patients with transparency, just like Nassim mentioned about why we ask these questions and how that data will be used. The second point, and Talia mentioned this in the review, is that we are ensuring that access is tightly controlled to this data. So currently, the access to the data is one-to-one. So if I'm seeing a patient, I have the chance to look in their electronic medical record and would have access to their health equity questionnaire answers. And that could help inform my interaction with that patient. And if we were considering to use data at a system level, our intention is that if it's used for quality improvement, planning, or reporting, that it's de-identified or aggregated so that we ensure individual patients cannot be identified. And over the last 3 years, we actually intentionally limited data analysis to just completion rates as we worked on further data governance pathways and community engagement, because we know that when we look at population level data, analyzing that data is really important to have community partnerships to really understand what that meaning making is of that data, and making sure that we're not labeling or that we're not stigmatizing or we're not making an equitable separation that worse. So our first 3 years of this work really leaned into how are our patients doing with completing the survey? How are they feeling about completing the survey? What are they not answering? And that's actually leading us into some work about understanding what makes a patient answer the questions and what makes a patient not answer the questions. And so hopefully that will give us some more insights into understanding how to get more engagement and representation. One of the things that we did know and notice early on is that we wanted the HEQ data used to be governed by clear decision-making structures. And we learned this from our work in research, that we have a body that sits and reviews requests coming through. And we felt like this would be important with respect to this data as well too. And we started it with a very small group of what's called the Social Determinants of Health / Quality Improvement Data Working Group that actually had members all seated around the table here. So from quality improvement, patient engagement, and community engagement, from research, as well as from the Social Determinants of Health Committee. And one of the things that we do is we actually take requests in and we review those requests for the health equity questions data. And what we want to do is to build that team up a little bit more and perhaps even include patient partners so that we can ensure that the review of data requests are aligned with our organizational priorities, equitable goals, the ethical use principles, and also ensuring that they're patient-centered and relevant, and that the meaning making that we have is also appropriate as well, and making sure that we're not moving towards anything that could stigmatize or harm communities. And so setting up a formal working group that actually looks through those requests for data from our health equity questionnaire. And how do we make our decisions in that working group? So we were fortunate enough to have a partnership with Unity Health Toronto, who had been working on and has been working on a framework for health equity data collection and governance, such that, once again, equity and trust are right at the top of how we actually vet and filter requests, and that the data is never used to label or exclude patients, but that it's actually used to identify structural gaps, such as unmet needs or inequitable access, and help us to guide system level improvements. And so with that partnership, we've had some framework of approach, which has been really helpful, and I'm sure happy to share that as well too. But the other thing that we also committed to is really thinking about the community context, the patient voice, and having some cultural humility in how our findings are interpreted. And recently, all members of the Social Determinants of Health Quality Improvement Data Working Group participated in completed OCAP training. And this was so that we actually are able to support better understanding of Indigenous data governance principles and really start to be more prepared on how to actually have an understanding of where data lies and whose data it belongs to. So I think that was really important learnings from that. And then one of the things you've probably heard which is really helpful is, and perhaps something that we're also noticing, is that this is a learning process. And so we've approached data governance in an iterative manner, taking small steps and looking at building our policies, thinking about our access rules, using cases to review regularly as we sort of build our understanding, and thinking about new risks and opportunities that are emerging. And this sort of ensures that the data remains a tool for learning and improvement and not surveillance, and that we're coming back to that central ethos of equity and trust as being the center of this. And we know that we'll never get it perfect on the first try, and that it's important for us to try, but also be willing to learn and think about continuous learning in this process. So in short, we've been doing some work in this area, but what we're leaning in towards with respect to governance is how do we protect our patients when they're sharing this data with a relationship of trust? How do we think about building equitable responses and equitable programs, but also think about enabling responsible learning from the data that we have and using a framework to actually help us understand when data is needed, how it's being used, and how it's being reported, and having some transparency, accountability, and trust in that process. Hand it back to you, Dr. Gupta.
Thanks so much. I hope the audience is hearing that this is a learning process for us too, and we're sharing with you kind of the iterative steps that we've made over the last 4 years, and that data governance is not easy, and it requires a lot of thought, time, collaboration, understanding about processes and kind of where you're embedded in a health system. I hope it's come to light how important and significant data governance is in this process, especially when holding such sensitive and important data. And so we're hoping that the next set of questions will really elaborate on how we've tried to work towards stakeholder alignment to kind of reach consensus around how best to do this. Like, this is certainly a team effort to do this well. And so I think I had mentioned in the intro that we held something called a data governance workshop, and this was really intended to bring people together. I'm first going to ask Talia to just tell us about who the different stakeholders were that kind of came to this table, and then I'm going to hand it over to Noor to talk globally about the role of this workshop, and then Nassim to really highlight the strong patient voices we heard and how that continues to design our future steps. So over to you, Talia.
Yeah, so as we've mentioned, we held this half-day long retreat, and we thought really intentionally beforehand as to whose voices we wanted in that room, and to make sure we were just inviting as many perspectives as possible. So we ended up having 26 attendees on the day of. It was a great turnout. I think all but one person we invited was able to attend. So there's really lots of interest for the people we invited to come to this event. And the people in the room held quite diverse perspectives. So we had several family physicians from the family health team who had been interested and participated in this type of work in different ways to come share their experience. Other allied health professionals from the family health team. We invited leaders from Unity Health Toronto who had been working on this data governance framework on the Unity Health Toronto level to come sort of let us know about what they had been working on to make sure we were aligned in those priorities. We invited several patient representatives to come and share their experiences, and then also some people on the research team that had been working on some of the back-end research related to this work. And so all of those voices together in the room really brought really fruitful discussions, and we learned a lot. So I'll pass it over to Noor to discuss what that looked like.
Thanks so much, Talia. I think just from Talia's excitement, you can hear some of the energy that was actually buzzing in the room when we brought all of these interest holders together. And it was an intentional space that was made, and the goal was not to start with solutions as to like how do we actually govern this data, but actually we started to leave it with an open-ended question of why is it important for us to govern, why governance mattered, and what were some of the risks that we were wanting to notice and wanting to make sure that we mitigated, and what decisions we needed amongst the table to say, in order for us to move forward, are we ready to move forward with using our data not in a one-to-one perspective, but now at a organizational level? Were we as a collective comfortable with it, that we had enough representation within our data set? And it was helpful to have all of these interest holders at the table because it all meant that we contributed to what would become the final output of a data governance framework. And during the retreat, we actually worked through real use case scenarios and asked our team to really come up with what were some of our assumptions, what were some of our tensions in this process, what were some of our blind spots. And unanimously, a lot of our team members shared that I think we're ready. I think we've been caring for this data. We provided enough of a protective shell around it, but we owe it now to our patients and our teams to actually share where we're doing well and where we could do better. And we owed it to all of the patients who had shared their information personally to provide them with what are we going to do about it. And so I think that was really helpful to hear. It gave us a boost of confidence. And it moved us from abstract principles of we have this data to actually some decision making. So thinking about creating a checklist for teams that are going to embark on social determinants of health research or quality improvement, and what are some of the things that they would need to consider before embarking? What do teams need to think about when they are thinking about analyzing data? How do they hide appropriate fields if we don't have enough of a response from a certain demographic? And so starting to come up with those kinds of reflective questions for our community that's interested in using this data, and how do we actually create some equity safeguards as well as flexibility in using this data. But one of the things that I think I was most fond about this idea of holding a retreat, that certainly food and warm tea and cookies made possible, was generating a feeling of psychological safety, where all voices mattered and were important in terms of how we use health equity questionnaire data and social determinants of health data. It sort of allowed for this opportunity for the same amount of trust and respect that we began the project with to continue with and move us forward with. So I think one of the things that has been really opportunistic about that idea of having a retreat where people can share their ideas is that they actually help to shape what the outcome is, and shape what our data governance structure will look like moving forward. So it came, what was really nice culmination was an alignment on values and decisions that will now allow us to be ready, or feel a bit more ready to start thinking about our data in more operational terms. I'll hand it over to Nassim.
Thank you. I'll say a little bit about sort of what it was like for patients, or what we heard from patients in terms of being involved in governance, or being involved in the retreat itself. For sure, our patients were happy to be there, so that's kind of the first thing I'll say, and not so much from the perspective of being offered the opportunity, but from the perspective of feeling like that's where they should be, that they should be at the table, that this is what's the right way forward, that from the sort of beginning of these journeys, we should involve our patient partners, and not in the middle and not in the end. And so I think from that perspective, folks were really happy to be at the table. I think maybe everyone on this webinar may or may not have heard Nothing About Us Without Us. So that's certainly a principle that our patients have shared with us and have taught us. We want to ensure that the populations that we are asking to complete these surveys are at the table with us and represented in terms of the decisions that are being made, and how we're asking these questions, and what we're doing with this data. So from that perspective, our patients are really the most important voice in terms of what is happening with this data after we collect it. And again, like how we are collecting the data. I don't know if folks remember, but many years ago now, there was a campaign that went out across the health system. We ask because we care. And that campaign really sort of bridged the gap between talking to, or using social needs data or social data, and talking to patients about what it's used for. And I think that language still kind of floats around the health system in terms of including patient partners in these types of decisions. And yeah, and I say that because including our patient partners in this retreat was also a way for us to bridge that gap. So for us to understand, how do we take this information and these decisions that we're making with these patient partners, and share that information more broadly, so that our patient populations that are going to be asked these questions have an understanding of really why we're asking these questions, and how it connects to their experience of care in general. And I think that our patients were, in a practical sense, really critical at the retreat and gave us a lot to think about. Just to give some examples, obviously we're coming from a family health team setting, so some things that came up were like, can patients self-refer for services that are available at our family health team, and you know, things like that can make a practical difference in the way that we practice. So it was very important for us to have the patients there, and in general, like for us to be lockstep in terms of our decision making with our patient partners at the table. And I'll turn it back to Dr. Gupta.
Thank you so much. Does anyone else have any final comments or thoughts? I want to thank everyone so much for joining us today for this 1 hour. And I want a big thank you to our panelists, Talia, Nassim, Noor, for taking time out of your day to share with us. I hope everyone has a great afternoon. Take care.